I want to thank Ellen this morning because she actually laid the groundwork for what I wanted to say. This work is extremely important, and one of the things that struck me yesterday and certainly struck me again as I was listening this morning and reading the papers is the extent to which it is validating a great deal of what we already know, and I think we need to take some satisfaction in knowing that. But it also raises a tremendous number of complications, and I think it leads to some challenges before we leave at the end of the day, particularly when we think about implications for policy and practice, because you're not going to go out of here with 100 policy recommendations. Yesterday, John said, distill your message, and as I was thinking about what it was we needed to take away, I was trying to figure out what it was we were going to distill from these that we could take back and use, and that wouldn't necessarily undermine what we're trying to do by overwhelming people. I was also thinking about an issue that was raised yesterday and again today, and I probably want to raise it again in the context of health, that there are no employers in the room. We've repeatedly talked about the need to engage employers, and I think when we talk about the healthcare sector, we also have to talk about people who are running healthcare systems, who in many cases are certainly both the employers and providers who operate the systems that serve the population. They're critical to any initiatives that are undertaken in terms of policy and practice, in addition to whatever happens in the adult education sector, and I think there are two strands of activity. So that's going to lead me back, I guess, to health and health literacy. Neither of these papers, in fact, dealt directly with health literacy. They were both talking about the interaction or intersection between health and literacy, which is very interesting to me as a Canadian, because when Canada first began to look at these issues, we looked at it as health and literacy and the intersection. And we only started to talk about health literacy in the early 2000s, after the United States had taken that direction a number of years earlier. I actually think we may have been on a better path when we were looking at health and literacy, and that we really need to see how these two mesh. But I do want to pay some attention to that. I also want to draw a little bit on some of my own background work in health and literacy, all of which touches on the two papers this morning. I've worked for about 20 years in health and literacy, in addition to literacy in general. And I was one of the people who constructed or authored what's known as the Calgary Charter, which some people in the room may be familiar with and some people may not be familiar with. But it basically was a statement of principles about what principles had to underlie health literacy curricula. And it grew out of an institute somewhat like this one that we ran in 2008 on health literacy in Calgary, which gave it its name, attended by a lot of people from the States and from Canada. And at the end of the day, we recognized that after looking at what was going on in health literacy programs and courses across schools in the United States and Canada, that there was no consistency in courses that were called health literacy courses. And there wasn't any necessary outcome that was common across them. In fact, the majority of them tended to be plain writing courses or communication courses, and were not broadly health literacy at all. So we decided that we needed to have some document that defined what the principles should be, and we constructed the Calgary Charter, and it's still being quite widely used. If people are on the various listservs for health literacy here, you'll see that people frequently refer to it. Julie McKinney was actually one of the authors. Andrew Pleasant was another one. Cliff Coleman was another. I was one of them. Irv Rootman, who was very active in health literacy in Canada, was a final one. And my Rossi in Massachusetts was the last of the six. What we ended up with was a document that talked about the need to look at health literacy as an issue that affects individuals and providers, and that you had to look at what needed to happen for individuals, but also what needed to happen for systems. And one of the things that I guess I need to think about in terms of what we've heard today in these papers is, what are the implications for individuals, and are we placing too much of the responsibility on individuals? Because in healthcare, a good deal of what has to happen that's going to make really significant differences in the outcomes has to happen in the healthcare system and by providers, and that engagement is absolutely critical. The good news, I think, is that a lot of this research has been done. I mean, the amount of research that has been done in health and literacy in the past 15 years is absolutely incredible. It's grown exponentially in the last 5 years. There are right now in PubMed over 7,000 articles on health and literacy in a variety of areas, whereas in 2010 there were just over 2,000, I think, something like that. So the growth has been enormous. What does it mean in terms of what we heard this morning? Well, I was struck by the first paper when I read it because I'm quite interested in the way people access information. And I also recognized that the authors acknowledged that they only looked at the first stage. They looked at functional literacy. Functional literacy is not enough. Functional literacy is insufficient. Knowing where to go is certainly a first step. The question then is, what do people do with the information they get? Do they understand what they're getting? Can they make critical judgments about it? The whole notion of functional literacy derived, again, from Don Nutbeam in Australia, who coined 3 levels of literacy, health literacy. He called them functional, interactive, and critical. And he talked about them being an absolute precursor to empowerment for individuals, that people needed to be led along these paths in order to be able to participate and take some responsibility and engage with healthcare providers in their own care and in preventive measures. And he was particularly interested in health promotion. So I guess we come back to the question, when you look at only the most minimal level of access, are you actually getting at the questions that you need to be getting at? If these are the numbers of people who have access, what does it mean about taking people to the next stage? And what is it that we need to be doing? And is it the part of individuals to make those accommodations? I mean, I would argue that, in fact, in almost all of these areas, the accommodations need to be made on the part of the system and the providers. And so an awful lot of the training that needs to happen for healthcare providers, and the changes that need to happen, very much like what Ellen talked about today, have to happen inside the healthcare system. So those, oh, sorry, I thought that was, I was going to say we already. I didn't think I'd been talking that long. So, you know, that was certainly very great interest in the media that are being used by people with low literacy, numeracy, and PSTRE, and the distinctions among them. And particularly, I don't think, Jan, you mentioned it this morning, but in your paper, you actually did highlight the fact that print is still incredibly important. And so the idea of making accommodations and simplifying materials is important. But internet is not just about print being transferred to internet. And I was a little bit surprised, I think, even in some of the conversations we were having yesterday about digital literacy, but not acknowledging the complexities of what's going on the internet, because there is way more than print on the internet. There are visual components, there's visual literacy that's required, but there's also an oral component. And so the opportunities are as great as the barriers. I mean, the internet, what's on the web, gives you the opportunity to have people listen to your instructions, to have them watch demonstrations, and these things are already going on. They're already up there. Very, very little. I have no idea how frequently any of the people that you interviewed, or whether you couldn't even get this information actually from PIAAC, which is going to be, my next question. Is what people actually did when they went online. Were they just looking at print information? Were they just Googling? Were they actually making critical judgments about who was putting the information up and where it was from? Were they watching demonstrations? Were they listening to something repeated for them? Again, one of the benefits of something on the internet is that A, it can be updated very frequently, and B, people can play it and play it and play it and replay it over and over again without feeling stupid stupid. I mean, I do that all the time. I look at something and say, yeah, let me listen to that again. Let me listen to that again. People won't ask a healthcare provider easily to repeat something because they're going to think I'm stupid. In fact, one of the tenets right now in provision is that healthcare providers should use teach back. Teach back meaning that you give people an opportunity to explain what they understand they need to do with the information, and then say, you know, maybe it would help me if you showed me again. Not saying, do you understand? Because if you say, do you understand, everybody says, of course I understand. He's going to think I'm stupid if I don't. So that was interesting to me, the use of the internet and also the opportunity that was there. Family and friends, again, family and friends, we found from a lot of the research we've done that family and friends, particularly with people who have limited skills, are critically important, but so are they critically important in immigrant communities. People trust the people in their own communities. They use them as venues. And so I'm going to go back to one of the points that Ellen raised today. I think Anita yesterday talked about the unobservables and the things we're not getting at when we only look at PIAAC to try to do this kind of analysis, because the complexities of the way people look after their own health, interact with the healthcare system, go way beyond skills. I was also interested in the health-seeking information behavior, because the two authors that you referred to in your paper both happen to be colleagues of mine. They're both professors at McGill. And again, the complexity of health-seeking information behavior is quite overwhelming, and it isn't necessarily predicated primarily on skill. There are an enormous number of other factors. There are anxiety factors. There are trust factors. There are social network factors. There are many, many factors that need to be taken into account. And it's not clear that simply looking at skill and doing this kind of analysis is going to tell us what we need to know. I'm going to flip to the second paper, because that one, I have to tell you, really surprised me, right? There were findings in that caused me to step back. Both the findings about who gains effect, the people with master's degrees or more, think, okay, I mean, that might not be surprising. And the fact that literacy is not as strong a predictor as we might have thought. Certainly literacy scores, right, are not as strong a predictor as we might have thought, because I have to tell you that people who are working in the sector right now are constantly using that message. I've heard this repeated over and over. Literacy is the strongest predictor of health status that you can use, that you pay attention to it. Does that mean we need to step back now and rethink that message? Because it's a message that we've been promoting, certainly inside the health system. When we talk to doctors, it's one of the things. We go in with these data, we put them up and say, and we know that literacy is one of the strongest predictors. You caused us at least to step back and question, is this actually the case? Do we need to do further research on this? Do we need to validate it? But we need to be careful about what the messages are that we take forward. I was interested in the extent to which some of these skills or some of the suggestions, certainly from the first group, they were almost totally for adult education, and I think they do have huge implications for adult education. But again, adult education and even our K-12 education needs to have some very profound changes made to it. These are the long term. These are the things that have to happen over a very long period of time. The more immediate, I think, challenges are what can be done inside the systems as they exist today. And again, I want to look at some of the things that are already in place, where at least policy and practice-wise you may want to think about building on those. There's been all the work done at the CDC here on what it takes to be a health-literate organization, which talks totally about systems and how organizations need to reorganize themselves and provide leadership and provide training and provide patient-centered care and be sensitive to the needs of their community. These principles are already out there. Guides are out there. I think one of the things we need to do is try to make sense of what we've already got. It's not so much what we need to do new. What have we already got that can help us move in the direction we need to go, and then what do we need to add to it, and what additional questions do we need to be asking? Digital, your digital pathways, Steve, I think are absolutely critical for healthcare in the future. More and more and more of what stands as healthcare is getting onto the web. You have electronic records. You say, oh yes, everybody's going to have access to their records. Well, if people have difficulty accessing online, or people have difficulty making sense of what's online, or reading a report of blood tests online, what does that actually mean? We're raising the demands at a level that's unprecedented and leaving behind masses of people. And this includes, by the way, not just people who score at low levels of literacy. One of the papers, I think it was the paper Jan put out, actually had one sentence. I thought one sentence is not enough. It says everybody is challenged by healthcare information. When we did our study in 2003 after the International Adult Literacy Assessment, when you did NALS here, you did your health literacy profile. We also did one in Canada, and ours was much broader than yours. We actually had 193 items on ours, and we ended up with unbelievable amounts of data. And at that point, we found that 60% of Canadians said they didn't understand healthcare information as it was currently being provided to them. 60%. And we went back and used that and said, when this proportion of the population can't make sense of health information, the problem doesn't sit with the individual. The issue sits with the way this is being done. And so we take it back to you and throw it back. And I think that a lot of the mechanisms and frameworks are already in place to do that. I think in healthcare and health literacy, it's one of the areas that's probably most developed, and there's a lot of hope. Universal precaution is something that has been promoted very widely here across countries. And universal precaution says you don't adapt for people with this level of literacy and this level of PSTRE. You do this for everybody, and you assume that when you make things accessible for everybody, you're going to be helping people at the lowest levels, and then you do other things on a one-to-one basis for people who may not have the skills you need. Again, I'm going to move to the digital and say I envisage a world where you will eventually be able to ask people how they like to learn, how they learn best, and accommodate them by providing the information for them in the format that they want and at the level that they want. And you'll be able to do that because you've got the ability in your own, in your own area to do that. It's still down the road, and there's a long way to go before we get there, but maybe not as long way as we think. So I guess overall, I'm really heartened to see this kind of work being done. I'm also a little bit, I'm somewhat fearful. I'm fearful about the message that we're going to distill. I would be very worried, for example, if somebody pulled some of the pieces out of context of your paper and then said, oh, look at this. Literacy really only accounts for this much. Why should we be doing this much? I think we have to be very careful about looking at a very broad paper, a broad perspective, a broad framework. I think we also need to be very careful about paying too much attention to one data set and using it for too much policy direction. I think we've always used the verb inform policy, and for me what this needs to be doing is informing policy and informing practice, but not actually, you say we're doing this because it conforms to PIAAC, right? This is going to match PIAAC. I think this is something that was done to some extent, not in the States. It was certainly done in our country in the past, and it was a dangerous road to follow. It's not one you want to take. I think the issue is, how does this information, how can it inform, and how can you distill it so you're going to get the best possible uptake? And how are you going to engage the people who need to be doing it? Because a lot of them aren't in this room. The people who are in this room are engaged. How are you going to engage the people? What are the messages? Partly, it has to be by speaking their language. There is a language issue here. There's a translation issue here. They don't speak the same research language. They don't speak the language. They wouldn't come and sit here for a day and a half. No, they wouldn't. They wouldn't. Okay. You really, so I've actually written a health literacy course online for doctors in Canada, an introduction to health literacy, and it was one of the most chastening experiences of my life. Okay, I mean, I was in learning mode for over a year, but wow, both because I had to learn how to write for the web, but I also needed to understand what doctors were willing to hear, what they were willing to take up, and sometimes rejected. You know, I'd say, I recommend that you look at this, and they, we don't want that. And you say, but this is really important for this reason. We're not interested in it. One of the things that was very positive is that we did the first of those curricula in 2010, and in 2012 it had to be reaccredited. In 2010, I had said there needed to be a module on the web, and they said, no, they don't want it. And I said, it's critically important. We don't want it. Put a paragraph in. So we put a paragraph in. In 2012, the evaluators came back and said, in the new module, we'd like to have a whole section on the web. We had also said cultural competence needed to be in there. No, we don't want it. In the new one, they said, put in something about how to work with our minority populations and immigrants and seniors. And so that says to me that over 2 years, thank you, there was growth. And it gives me hope that if we find the right way of engaging with the people who have to take this forward, we can do something of great value for the future. So thank you.